Here comes the slowdown. Good morning. Good morning. On computer.
Yeah, I was just doing it. So I like left oh, I didn't miss that play. I knew what was happening. I'm tired.
John, how'd your game go? Not that good. Get him next time. Okay, good morning, all. Daylight savings time just kind of gets you right in the pillow, doesn't it? And then we have to wake up to darker skies. Not a fan. Not a fan, but it's the way we do things. So as the days get longer, it'll get a bit brighter out there. You just wait and see. So for now, yeah, it stinks. That's the way it goes. Okay, we'll run through these slides from last time that I didn't really get to as much as I should have. Then we'll get into clinical use. of antihypertensives. And then after we finish antihypertensives, come on, voice, we will talk about the treatment of angina and congestive heart failure. Let's start with a word of prayer. Lord, thank you for today. It's a little cooler out, a little earlier. Please help us brush the sleepers from our eyes. Thank you for this time to be together, learn together. This tough subject, this subject that is difficult, but these students have gathered here to learn about now. Help us do just that. Thank you for traveling mercies for our athletic teams. Now, Lord, help us have traveling lecture time mercies. In Jesus' name, amen. Okay, so the beta blockers, as we said, they are going to decrease the cardiac output part of this little makeshift equation that we came up with. So blood pressure will depend upon the product of our systemic vascular resistance and cardiac output. Beta blockers will decrease cardiac output. They do that because they bind to the beta-1 adrenergic receptors, which are found in cardiac muscle. So they will slow the heart down. They'll decrease contractility of the heart muscle as well. So they are sympatholytic drugs. They prevent activation of the heart by the sympathetic nervous system. That's why they're termed sympatholytic. We talked about two beta blockers in particular that are partial agonists of the beta-1 receptor. Those are pindolol and acebutolol that are partial agonists, so they possess intrinsic sympathomimetic activity. That term, sympathomimetic, bit of a tongue twister. Sympathomimetic drugs are any drug that activate the sympathetic nervous system. So for example, you'll see these chaps in the gym. Before they start lifting, they cork something and they'll chug it. If you look at the cans, sometimes it'll have this stuff in it called ephedrine. Ephedrine. And ephedrine is a sympathomimetic. In colloquial terminology, it jacks you. Okay, I saw Josh's eyes get big. Oh, I know what that means now. So when you think of sympathomimetic, right next to it, jacked up. So get your heart rate racing, dilates blood vessels to muscles. That's why it's used in pre-workouts. I don't recommend its use, by the way, but it's in pre-workouts and stuff like that for that reason. There are some membrane stabilizing activities of beta blockers. These aren't a huge part of the pharmacology of beta blockers, but they do have membrane stabilizing activities. Now, we talked about the non-selective, selective, and then the ones that possess the vasodilator activities. So the non-selectives, what's our mnemonic for those? New Zealand. So remember, that's drugs like pindolol, nadolol, propranolol, sotalol. Remember, they all start with letters between N and Z. So these are non-selective. They antagonize both beta-1 and beta-2 adrenergic receptors. So these will tend to have more side effects Propranolol, remember, is lipid soluble. It crosses the blood-brain barrier, and therefore it's used to treat migraine headaches. Migraine headaches. Decreases blood flow to the brain, and that is one of the aspects of migraines, vasodilation in the brain. Generation 2s are cardioselective. They have a far higher affinity for the beta-1 receptor than they do for the beta-2 receptor. So they are selective, and they have fewer side effects than the first generations. What's our mnemonic for these? Armadillo. They start with A through M. You can use these in patients with asthma, so on and so forth. And then the third generation, there's two drugs, labetalol, carvedilol. Carvedilol we'll see again when we look at treating congestive heart failure, because it's used for congestive heart failure. Labetalol is used for hypertensive emergencies and for chronic hypertension in pregnant women. It's safe during pregnancy. Beta blockers in general are contraindicated during pregnancy, except for labetalol. They tend to cause low birth weight because of decreased blood flow to the baby. So here's just a picture showing you that these two receptors, they bind beta-1, beta-2, they bind norepinephrine and also epinephrine. They activate G protein coupled receptors. They increase the synthesis of cyclic AMP. Cyclic AMP activates protein kinase A, which phosphorylates the L-type voltage-gated calcium channels. When you phosphorylate L-type voltage-gated calcium channels, you activate them. So they now open much more easily. When you block these receptors, you block this response. So you block the ability of cells to depolarize more quickly and to also release their internal stores of calcium more quickly. That's the reason why these drugs slow the heart down. So they show a so-called chronotropic activity. That is, they decrease the heart rate. That's called chronotropy, negative chronotropy. They therefore also decrease contractility. And in this picture here, with less calcium, you get less contraction. So they have decreased contractility. So that's negative inotropy, negative inotropy. They also decrease the velocity of conduction through the conduction system of the heart. So that's called negative dromotropy, negative dromotropy. And then they decrease the relaxation rate. Because they decrease the relaxation rate, the cells spend more time relaxed. That's called negative lusitropy, negative lusitropy. So lusitropy, think relaxed, loose. Nice and relaxed, lusitropy, staying loose, nice and relaxed. Dromotropy, the way I think of this one is dromedary, a camel's hump. So like an EKG, it's a camel's hump. So the EKG now spreads out just like the humps on a camel. That's my dumb way of remembering it. Dromedary, dromotropy, close. Well, not really close, but closer than trying to remember it. And then this one, ions, inotropy or onotropy, for contractility. Then chronotropy, that one, chronometer, that one might be a little easier to remember. Because they block cyclic AMP synthesis in cells, cyclic AMP in vascular muscle plays a different role than it does in cardiac muscle. And in this case, at least with various vascular beds that feed certain tissues, such as skeletal muscle and the brain, when you activate beta 2 receptors, you actually cause vasodilation. And that has to do with the myosin light chain kinase. The myosin light chain kinase. So increases in cyclic AMP inhibit the myosin light chain kinase. Therefore, you get more relaxation in these vascular smooth muscle cells. Vascular smooth muscle cells contract in a different manner by a different mechanism than do cardiac muscles. They still use actin and myosin, but smooth muscles don't have troponin like cardiac muscles and skeletal muscles do. Instead, the contraction leads to a change in cell shape. Also, the smooth muscle tends to be around the periphery of the cell, not in the center of the cell like in a cardiac or a skeletal muscle. So with these, if you activate beta 2 receptors, you get relaxation of that vascular smooth muscle. And here's a picture to show you. So this happens. This is again the case for vascular smooth muscle. You will make cyclic AMP because your ligand, norepinephrine, binds to the beta 2 receptor. This will then inhibit this myosin light chain kinase. If you don't phosphorylate myosin light chain, you don't get contraction. We'll see that other drugs are involved with activating the phosphatase. They also cause relaxation as well, but with beta 2 receptors, they will cause relaxation to skeletal muscle and to the brain because of this mechanism here. Cardiac effects of beta blockers. So they will decrease heart rate, decrease relaxation rate, decrease contractility, decrease conduction. This decreasing conduction velocity makes them useful for treating certain types of cardiac arrhythmias, in particular, tachycardias. So they're useful for atrial fibrillation. And they're also useful for supraventricular arrhythmias, particularly those involved with reentry. Quite useful for that, and that's largely due to their dromotropic activities. You get mild vasoconstriction in skeletal muscle beds and in the vessels that go to the brain. The clinical significance of this is minor, although it seems as though on beta blockers that are non-selective, you get more fatigue because of decreased blood flow to the skeletal muscles. So what are they good for? Here we go. Good for hypertension, good for angina, that pain you get in the heart if you don't get enough oxygen to the cardiac muscle. They are particularly good after a heart attack. So after a heart attack, you can get arrhythmias, and beta blockers will prevent the arrhythmias. They also spare cardiac muscle. They're quite good at that. In fact, and some cardiologists, after you have a heart attack, they will put you on a beta blocker automatically because they tend to spare the cardiac muscle. Prevent the heart from enlarging. That's called remodeling. Several studies have shown beta blockers prevent remodeling of cardiac muscle. Arrhythmias, good for arrhythmias, and then good for heart failure, albeit, as I said before, Their role in heart failure is controversial, even though 2 beta blockers have been shown to have a positive role in treating heart failure, that being metoprolol and bisoprolol. Metoprolol and bisoprolol. So as I said before, they decrease cardiac output. They're used for hypertension caused by emotional stress. If you have patients who are prone to panic attacks and their blood pressure is high because of emotional stress, beta blockers are very effective in these patients. And they're used in the preoperative management of hypertension caused by something called the pheochromocytoma. These are tumors of the adrenal gland that cause large amounts of epinephrine, norepinephrine. And if you're trying to get the blood pressure down before operation, you use a beta blocker. Quite good for that. Because beta blockers decrease cardiac output, they decrease oxygen demand by the myocardium. And since angina is caused by this mismatch between oxygen demand and cardiac activity, beta blockers will equalize those 2 things. So they're very good for treating angina. They're also good for treating certain types of arrhythmias. So as you can see here, because they decrease conduction velocity, they can treat certain types of arrhythmias. They decrease the sinus rate, decrease conduction velocity. They can inhibit aberrant pacemaker activity if you have other cells in the atrium, or for that matter, in the bundle of His or the AV node or something like that, that are trying to be a chief rather than an Indian in the beating heart. Beta blockers are very good at saying, stop that. And they also are very good at preventing arrhythmias caused by reentry. They are the drugs of choice. So beta blockers are also, several of them are type 2 antiarrhythmics. Type 2 antiarrhythmics. And for heart failure, as we said before, these 2 drugs right here, metoprolol, bisoprolol, they have been shown to improve cardiac function and reduce mortality. That's probably one of the biggies here. And in general, increase quality of life in people with heart failure. They will also decrease the enlargement of the heart that occurs during heart failure, so-called cardiac remodeling. I don't want to go over these again. Consult a handout in your list of your booklet of handouts. We went over these already. Side effects, I went over these already, but I emailed you and said that fatigue was one that I left out. When you first get on a beta blocker, usually for the first 2 weeks, you'll be out of breath, you'll be really tired. Your body will adapt to it, usually after about the first week, week and a half, 2 weeks. You don't use beta blockers in people with a block. If they have a heart block, you don't use beta blockers. If they already have sinus bradycardia, you don't use them because it just makes the bradycardia worse. Also, Raynaud's syndrome. Have any of you heard of Raynaud's syndrome? Yeah, and they turn blue, especially in the cold. There's different triggers. Cold is a common trigger. So usually from right about here on up, your fingers may turn blue. It's associated with some autoimmune diseases. Other people just have it. And it's not linked to anything. But if you have Raynaud's syndrome in the cold or some other trigger, your fingers get really tingly, they get really cold, they start to turn blue. beta blockers make Renault syndrome a lot worse. So if you have Renault syndrome, you don't use beta blockers. That's another contraindication. And then with the exception of labetalol, you could also put in here pregnancy. Can be in some people. In a lot of people, it's managed quite well. If you use hand warmers and gloves and things like that, there's also certain medications you can take when it comes on. It's usually caused by a vasodilation that occurs. Some viruses will actually cause Raynaud syndrome in some people, and it can be managed. Long term, yeah, it can be big trouble for your fingers, but there's usually it's temporary, and usually it's very manageable. So typically, the answer would be typically no. We talked about many of these other side effects already. For diabetics, the tachycardia that accompanies insulin-induced hypoglycemia is masked if you have that patient on a beta blocker. So they should be used with caution in diabetic patients. GI upset, sleep disturbances, impotence is definitely one that you see in most people on beta blockers. Very good. All right, are there any questions from beta blockers? We talked about these Friday, went through these. Any questions? If not, we will go ahead and move to the use of the other antihypertensives in a clinical setting. Come on, machine. There we go. Not sure why I have to click everything twice. Very good. All righty. So hypertension simply refers to that condition in which the blood pressure is persistently, this is the word we're looking for, persistently. Those of you who are HES majors, we have to take each other's blood pressure to practice in classes. And you take the cuff and you'll take each other's blood pressure. You'll probably notice blood pressures vary throughout the day. That is a well-documented fact. Your blood pressure usually, when you're asleep, is rather low. When you wake up, it's low, and then when that cortisol wave kicks in, your blood pressure spikes in the morning, then it tails off, and then throughout the day, it goes up and down, up and down, up and down, up and down, within a certain range. You're looking for someone whose blood pressure is persistently high. Persistently high. And if you get these cases where someone's blood pressure is really high when they come in, but you then retake it and it's normal, it jumped up when they came in, they got nervous. You need it to be persistently high. The measurement is indirect, blood pressure is silent. You can't look at someone and say, oh, they've got high blood pressure. So it's a silent thing. That's why it's sometimes called the silent killer. Hypertensive crises refer to acute, life-threatening spikes in blood pressure. These spikes will be associated with end organ damage because of damage to the capillary beds within those tissues that feed those tissues. High blood pressure over time puts strain on the heart. The heart now will start to enlarge. Also, the vessels, in response to that constant stress, will start to undergo hyperplasia of the smooth muscle. And so the vessel now, with extra smooth muscle, will go from this big to this big. That's a case of chronic hypertension. And chronic hypertension means you're going to chronically be putting pressure on the heart. You're a candidate for heart failure. That's why you want to treat hypertension if there is hypertension, and you want to treat it aggressively. So hypertension is definitely the most common primary diagnosis in America. Some 35 million office visits have as their primary diagnosis hypertension. 50 million or more Americans have high blood pressure, and the worldwide prevalence is probably as much as 1 billion people have hypertension. Some 7 to 8 million deaths per year are attributable to hypertension. This is not something that you want to take lightly. So the equipment that you use to measure blood pressure, you should inspect it, and it should be validated. My dentist started taking blood pressures, and the device they use is a wrist device. Those devices give different results depending upon how you wear it on the wrist. Also, the thing talks to you, and it says, make sure your arm is at the level of your heart. Well, at the level of your heart. So you're lying down in that chair. So do you do this? Do you do this? Do you do this? What do you do? And then, depending upon how it ends up being on your wrist, it'll measure it differently. So make sure that the people who use the equipment know how to use it. Yeah, operators should be trained, regularly retrained. Patient should be positioned properly, seated quietly, arm level of the heart. They don't tell them hold at the level of the heart. You hold it, because if they hold at the level of the heart, what are they going to do? They're going to tighten up. Okay, stay there, stay there, stay there, stay there. They're going to have a high blood pressure. You hold it, or put them in a chair with a rest that puts it at the level of their heart. The auscultatory method is used. That method simply is an indirect method of measuring blood pressure. And then no exercise, caffeine, smoking for at least 30 minutes before blood pressure measurement. And then the cuff should be the right size. I can't tell you how many doctor's offices I've been in, family doctors. The nurse comes in with a kid cuff and puts it on you, and she pumps that up, and you're going, uncle, 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 because the cuff's too bloody small. So make sure the cuff is the right size. Yeah. Those haven't been validated usually. FDA says you can't use those for a diagnosis, but every doctor I've talked to says they're better than the machines we have in the office sometimes. Yeah, and now there are devices, apps you can get on the Apple Watch. It'll send it to your doctor. Your doctor can watch your EKG in real time if there's a question about your EKG. You heard of this program, Tyto, Tyto? It's like $300 at the package you get on your computer. With that, you can look into ears, throats, noses of your kids, and the doctor can see the image, and the doctor can make a diagnosis at home just using those images that you're generating on your computer. Isn't that cool? That's pretty cool. About $300. Families now are buying them especially if they live out in the country, so they don't have to drive 5 miles to go see the pediatrician, which is pretty cool. You want to take 2 measurements, particularly one of them is high. You average the 2, and then you always don't do what some clinicians do, pump, 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 pump. Oh, it's fine. Okay, it's fine. Tell me what fine is. Because your idea of fine, my idea of fine, I hope they're both the same, but they might not be. Don't sit there and leave your patient in the dark. Tell them what their blood pressure is. All right, so you want to, if it's normal, recheck it in 2 years. Unless the first reading was in the rafters, then you might want to recheck later. Pre-hypertension, recheck in a year. Stage 1, confirm it within 2 months. Stage 2, evaluate or refer to somebody who can treat it. For those with higher pressures up in this range here, evaluate and treat immediately or within a week. Yeah, without acute end organ damage, you just retest, and if not, then you treat immediately. Basically, you want to make sure you're not treating someone who was just nervous and doesn't have hypertension, as opposed to someone who actually has hypertension. So pre-hypertension has been redefined. Used to be 120 to 139. Now it's 120 to 129. 120 to 129, that's pre-hypertension. Anything above 80 used to be 85, now it's 80. Diastolic is pre-hypertension. Pre-hypertension, mind you, is not a disease category. It's a designation for someone at risk of developing primary hypertension. I will get to the graphs that I'll show you that cause them to change the standards. Okay, now, if someone is pre-hypertensive, they're not a candidate for medication. They might be a candidate for lifestyle adjustments, but they're not for medicine. They, again, should be firmly and unambiguously advised to modify their lifestyle. That would include changing their diet, decreasing the amount of salt and fat they consume, increasing the amount of exercise, decreasing the amount of time that they are sedentary. So let's say you get, say, a patient or a client, their blood pressure is kind of borderline. What might be some advice you might give them? Now, if you tell them to start training for marathons, they're going to blow you off. What's something more practical they can start with? Less eating out, also easier on the budget. How about just taking a walk? Just taking a walk, 30 minutes a day can make a big difference. Take a walk. In fact, in England, you know what doctors will tell their patients? Get a dog, because dogs have to be walked. If you have a dog, it forces you to take a walk. So they will actually prescribe getting a dog, because the dog forces them to walk. And then if they're older and they're a tad on the depressed side, which most Brits are a little depressed usually, because of the weather for one thing, a dog also may also increase your mood. So they'll actually prescribe or highly advise that they get a dog. And that might be something you can suggest. Get a dog. Dogs have to be walked. So that might be one thing to motivate them to just take a walk. Also, JP is absolutely right. Less eating out, also less processed foods. less packaged foods, less TV dinners, things like that, more fresh fruits and vegetables, things like that. These are all things, you HES majors, this is kind of your bailiwick. However, if your patient's a diabetic, here's what you're going to do. You can take their blood pressure, and in your head, you can add 10 to it. Because diabetics have a environment, excuse me, in their blood vessels that is very inflammatory. Their blood pressure needs to be lower than usual. So if their blood pressure, say, is 129, in your head, it's 139. They need to be treated. We talked about isolated systolic hypertension. This is primarily seen in elderly males, more common after the age of 50. Your diastolic increases are more important usually before the age of 50. If someone has isolated systolic hypertension, this, in terms of management, it's not a separate sort of treatment, but it is a treatment that you take into consideration. As you get older, your vessels get stiffer. It's just a fact of aging, and that's the reason why. So here is the distribution of hypertension by age. You can see that as you get older, your tendency to get hypertension goes up, and it goes up pretty precipitously. So we have isolated systolic hypertension. You can see by the time you get old, you're elderly, the percentage of people with isolated systolic hypertension goes up, and then your tendency to have systolic or isolated diastolic hypertension, those tend to go down as you get older. It's more systolic hypertension that you tend to see as you get older. Hypertensive crises are broken into urgencies and emergencies. Urgencies and emergencies. So if an urgency means that you have no progressive end organ damage of any sort, but the blood pressure is too high. With hypertensive emergencies, otherwise known as malignant hypertension, you're now starting to see evidence of end organ dysfunction, end organ damage. You're starting to see kidney failure, starting to see retinal dysfunction, starting to see the heart going into palpitations, chest pain, trouble breathing, headaches, things like that. So hypertensive urgencies, your blood pressure is in the upper range of stage 2 hypertension, but it's without end organ dysfunction. So you're without severe headache, without shortness of breath or chest pain, and it's usually due to under-controlled hypertension, typically. With hypertensive emergencies, usually your blood pressure is above 180 over 120, and you start to see progressive target organ dysfunction. And these are just some sorts of things that can result from severely elevated blood pressure. Hypertensive encephalopathy, you start getting the fluid in the brain. Acute left ventricular failure with pulmonary edema, acute myocardial infarction, or unstable angina pectoris, or a dissecting aortic aneurysm. Usually that's an aortic aneurysm you already have beforehand, but dissecting means that the thing starts to pull away from the inside layer of the blood vessel. You start getting blood accumulating between the inner and outer layer of the blood vessel, and the blood vessel is going to pop. That, of course, is an emergency 3 ways to Sunday. Risks for hypertension. So these types of things can be major cardiovascular risks. This comes from the JNC7 report. That's from 2003. That essentially is what established the old standards. This study, however, has been ongoing. That's what caused the revision of the standards. So for hypertension, smoking is a biggie. Big smoking. Obesity also is a biggie. So is physical inactivity. So what is defined as physical inactivity? If you are sedentary for longer than a period of 2 hours a day, and if you're sedentary for 2 hours a day for at least 3 to 4 times during that day, that's usually considered too little physical activity. Now, what if you say you're on the baseball team and you work out at 6 o'clock in the morning for two hours, and then you come to class and your class, say, for 4 hours a day, and you're sitting for 4 hours a day, then your algorithm is going to be different. But if you don't have any major physical activity, but you're sitting for long periods of time, one group that falls into this category would be gamers. Gamers can spend enormous amounts of time just sitting. That would be defined as physical inactivity. If you have a job where you sit at a computer all day and you don't do anything outside of that, that would be physical inactivity. Dyslipidemia, blood lipid levels are high. Diabetes, kidney malfunction, microalbuminuria, protein in your urine, advanced age or a history of premature cardiovascular diseases. These are all cardiac risk factors. For target organ damage, any sort of things like this, these are all things that high blood pressure essentially can hasten. Everything from heart failure to a stroke to coronary artery disease to left ventricular hypertrophy, just means enlargement, retinal disease, peripheral artery disease, chronic renal insufficiency. These are all things that hypertension can contribute to. All right, so this is from the original JNC7 study. And they defined pre-hypertension 120 to 139, but then stage 1, stage 2, stage 1 was 140 to 159. Now it's 120, 130, essentially to 149. And then anything above 150 would be stage 2. With stage 2, usually you're looking at drug combinations to get the blood pressure back into this normal range. And usually with stage 1, it's either a thiazide type diuretic, or you may consider ACE inhibitor, angiotensin receptor blocker, beta blocker, or a calcium channel blocker, or a combination. For stage 2, usually then you want to try combinations to try to get the blood pressure down. Now, some people are very sensitive to drugs, and you give them one drug and their blood pressure drops like a rock. So some people in this range here may only need one drug, depends. So usually you start with one drug, then you layer drugs on as you need to. You start with one drug, layer drugs on as you need to in order to get the blood pressure back into this normal range. You're shooting for the pre-hypertensive range. That's what you're shooting for. And these are the new standards as of late 2017. And they also changed hypertensive crisis. If you end up at a hospital and your blood pressure is ridiculously high, and there's no indications of organ damage, you really don't do anything except just treat the high blood pressure. That changed some of the earlier recommendations. Used to be if their blood pressure was this high, you get it down, come heck or high water, whatever you need to do. Now you just treat it and you don't worry about it if there's no end organ damage. All right. So our tools in our toolkit are going to be these drugs here that are in the peach color. These drugs here can be used under unusual circumstances. These are the main drugs we're going to use: diuretics, beta blockers, ACE inhibitors, angiotensin II receptor blockers, calcium channel blockers. These others we will reserve for unusual circumstances. The sympathetic nervous system often plays a rather prominent role in hypertension. Usually you have activation of the sympathetic nervous system, so that increases your cardiac output. That's due to activation of these beta-1 receptors. In the skin and in visceral circulation, vasoconstriction caused by activation of the alpha-1 receptor will cause increased blood pressure in those tissues. However, activation of these same, of vessels in other places, liver, skeletal muscle, brain, actually causes vasodilation. In the lung, you get bronchodilation. Because of beta-2 receptors in the kidney, you get increased renin production. So these are potential targets then for treating hypertension. So if you inhibit sympathetic stimulation of the heart, that means you can drop cardiac output. You drop cardiac output, you can drop blood pressure. And that essentially is the whole thing behind beta blockers. Cardioselective will usually be what you'll select in cases like this, except under unusual circumstances. Non-selectives have their use, but for blood pressure, you're usually going to go with a cardioselective agent. So beta blockers will reduce the heart rate. They reduce cardiac output, reduce the force of contraction of the heart. They reduce renin and they reduce blood pressure. Okay, we've talked about some of these side effects already. The biggies are going to be, at first, you'll have bradycardia typically, and you also may have some fatigue, some exercise intolerance. People on beta blockers can still get their heart rate up to an exercise level because the norepinephrine you produce by exercise will overcome the beta blocker. Then when they stop exercising, the beta blocker will then kick in. So people on beta blockers can exercise. However, they'll find it very hard to exercise when they first go on the drug. So you have exercise intolerance, usually for about the first week or two. Then that will, in fact, just walking out to their car may prove difficult at first. Beta blockers can also mess with triglycerides. They can decrease HDL. This is the case usually with non-selective more than selective, but the selectives can still increase triglycerides to some extent. So watch lipid panels essentially when a patient goes on beta blockers. Bronchospasm is not common at all with cardioselectives. They can exacerbate heart failure. That's something to keep in mind. Sleep disturbances are more common in non-cardioselectives. Fatigue is pretty common at first. Depression is uncommon in cardioselectives, more common in the non-selectives. Impotence, that's pretty common with both sets. All right, so what are they used for? They're used for, we talked about thyroid storms, essential tremors. If someone is on the drug lithium, one of the very common side effects of lithium is essential tremors. So if you have the patient draw a spiral, usually instead of a smooth spiral, you'll get something like this. Propranolol has been shown to decrease essential tremors. And so propranolol becomes one of the main drugs that's given to patients who are on lithium to decrease essential tremors. They're used for angina, used for supraventricular or ventricular tachycardias, for perioperative hypertension, and of course for migraines. It's clear beta blockers are underused. So these are drugs with a lot of uses. So carvedilol and labetalol work to inhibit alpha-1 and beta-1 receptors. Their affinity for the beta-2 receptors is dose dependent. They don't have a high affinity for these. They will block them at certain dosages. Therapeutic dosage, you're not going to get much blockage of beta-2s. So it's mainly alpha-1 and beta-1s. So they will not only slow down the heart, they'll also cause vasodilation. So these will also cause postural hypotension. Postural hypotension. These are used for congestive heart failure. And then labetalol is the drug of choice for chronic hypertension in pregnancy. And it's also available in an IV form for hypertensive emergencies. It's usually very effective for that. And so here is a little panel showing you the cardioselectives, non-cardioselectives. Again, you will notice that if your drug starts with N through C, it's non-cardioselective. The exception would be cartilolol. Cartilolol is used for glaucoma. This comes as drops that you put in your eye to decrease glaucoma. That's the only indication for cartilolol. So when it comes to treating hypertension, cartilolol is kind of off the table. Same thing with timolol. Timolol is not used very much for hypertension. It's used mainly to treat glaucoma. So it comes as eye drops. Any questions about beta blockers? Let's go now to diuretics. So diuretics, you have your thiazide or thiazide-like diuretics, loop diuretics, potassium-sparing diuretics, and then carbonic anhydrase inhibitors that are only used for high altitude sickness. That's really all they're used for, frankly, nowadays. So really, it's those top three right there. So here are the main agents that we are concerned about here. So there's only 4 loop diuretics. Remember that ethacrynic acid is the one with no sulfur. So if you want to use these in a patient with a sulfur allergy, you use ethacrynic acid. Thiazides, all of them contain sulfur. So if you have a sulfur allergy, you're pretty much out of luck for thiazides. Potassium sparing diuretics. So spironolactone and eplerenone, which is not on here for reasons that I'm not too sure about, are the steroids. They inhibit the aldosterone receptor, whereas triamterene and amiloride, they inhibit the ENaC receptor, the ENaC channel that's found in the principal cells, in the DCT and the collecting tubule. And then these are the 2 carbonic anhydrase inhibitors you might end up using. Cetazolamide is definitely the bigger one of the 2. So these work in the kidney, And the kidney is composed of lots and lots of these nephrons. So these nephrons consist of the thalamus capsule. Then you have the proximal convoluted tubule. That's the site where the carbonic anhydrase inhibitors work. Then you have the loop of Henle. You have a descending, ascending, and thick ascending loop. The loop diuretics work in the thick ascending loop of Henle. Thiazide diuretics work in the distal convoluted tubule. And then potassium sparing diuretics work in the distal, the more distal part of the distal convoluted tubule and in the collecting duct as well. That's where those work. So diuretics decrease blood volume. So they decrease systemic vascular resistance. They're very good also if you have a patient who has edema. Edema. Very simply, you have pooling of liquid in various places of the body. If you want to get rid of that fluid, diuretics, they're very good for that. So they decrease blood volume, they decrease blood pressure, and they're also very good for dealing with edematous states. Edematous states. Diuretics can cause dehydration. So if you have a patient on diuretic, you have to make sure they are hydrating. Also, because you're losing more fluid, you're losing electrolytes. So electrolyte disturbances are your biggest worry. And the big one here is to worry about is potassium usually. Potassium. So with thiazide and loop diuretics, hypokalemia is your concern. With potassium sparing diuretics, hyperkalemia is your concern. You can get hyperglycemia as well, and lipid abnormalities as well. You may get hypotension, at least at first. With thiazides, you get photosensitivity. Loop diuretics can cause ototoxicity. That ototoxicity is reversible. It's reversible. They also can worsen gout. So they're probably contraindicated in cases of gout. Okay, that's enough for today. We'll finish this on Wednesday, and then we will start on treating coronary artery disease. Yeah.
Is there a focus series